Very good evening to one and all of you. I hope you can all hear me all right. And if you do, then you can just probably give me a thumbs up. That will uh, that will suffice. Yes, thank you. Well, let me begin by first of all welcoming each one of you to this evening, and for some of you it's morning, and we are going to have a lovely time of discussion and listening to a lecture, a talk as well on an important topic. But before that, let me welcome all of you on behalf of the entire Reasons to Believe APAC Foundation. And we are so glad that all of you are here. And I would like to thank each one of you for sparing your valuable time to be with us at this very moment. Now, before we go ahead, I just want to actually tell you a little bit about the Reasons to Believe APAC Foundation, who we are, what we do. For some of you, this may be your first time, and it would be nice if you can let us know from where you're joining. I see that some of you have already done that, but if you're joining and if you are new, do let us know from where are you joining, and we would love to be in touch with all of you. Now, very briefly, Reasons to Believe is APAC is an organization that is focused on actually dealing with science and faith issues. And we believe that science and faith are not sworn-in enemies. They are friends. And yes, we as an organization, we are committed to helping people engage with all the latest scientific developments and discoveries to actually demonstrate that all of this go hand in hand with what God has revealed in his word, and that is the scripture. We also actually are committed to helping people explore the different evidences that is available both in nature as well as in scripture. And we are committed to also engaging with people from different worldviews and so on and so forth. We also believe that we should examine what is it that we believe and why is it that we believe. So it is with that openness in mind that we are committed to actually conducting seminars, conferences, and even talks like this, so that we can actually share with you what we've learned and what we believe. And also in doing so, we also want to actually invite you to air your your questions that you may have as a result of you hearing the talk, especially at this very moment. Well, this evening, we are also going to have a talk on a very important topic, that is, are abortion drugs safe? Some of you have asked me already a lot of questions about the entire argument surrounding abortion as well. And I have responded to some of you that why don't you join in? And it is right in that very forum that we are going to answer some of these questions. And so this is very, very important for us as well. And yes, as I've said a few moments ago, that today when we look at the world around us, we find that science has actually come up with a lot of discoveries, a lot of advancement we have seen in just a span of 1 and 2 decades. And in these few decades, we have seen a lot of things that have changed, both scientifically, and very often the question is asked that it seems that there is no limit to what man can do. But just because scientifically we have discovered so much, we've made so much of advancement, just because there is a possibility of what we can do, that does not mean that it necessarily must be done. And more so, whether it is ethically right or wrong. So these are some of the questions that we will be actually discussing, and we will be hearing a very important talk that is given on this very title itself, Are Abortion Drugs Safe? And to do so, we have with us a very special guest who's joining us from the United States, and her name is Dr. Christina. And she is, in fact, a board-certified OBS and gynae, and has worked for 20 years in private practice. outside of Pittsburgh, PA. She received her Bachelor of Science in Mechanical Engineering from Virginia Tech in Blacksburg, PA in 1983, and then worked for 7 years in the engineering field before pursuing a medical career. So Dr. Christina earned her MD from Thomas Jefferson University in Philadelphia in 1994 and completed her residency in obstetrics and gynecology at the Medical College of Virginia in Richmond in 1998. She also earned a biblical ministry certificate from Columbia International University in Columbia in the year 2007. She's a diplomate of the American Board of Obstetrics and Gynecology and a life fellow of the American College of Obstetricians and Gynecologists. She is a member of the Christian Medical and Dental Association, the Pennsylvania Medical Society, and the Allegheny County Medical Society, and the North American Menopause Society, where she has received certification as a National Certified Menopause Practitioner. She is also a long-time member of the American Association of Pro-Life Obstetricians and Gynecologists, where she currently serves on the board of directors. She has published peer-reviewed articles in the medical literature on the complications of medical abortion, and Dr. Christina has volunteered her medical skills in various third world countries in Africa and Asia. She has traveled regularly to Bangladesh to provide medical care to women and at the Memorial Christian Hospital in Bangladesh. Doctor, we are so delighted to have you with us, and we would welcome you with an applause, and the time is yours now. And after that, we will have a time of questions and answer. And along the way, if you have your questions, please, friends, you can jot it down at the chat box. And from there, I'll be picking up the questions so that at least Dr. Christina can answer the questions for us. Thank you. Over to you, Dr. Christina.
Well, thank you so much for that introduction. You're so kind. And I want to thank everyone for coming tonight. I might say this morning because it's morning here, but thank you for coming tonight. I am going to be speaking on chemical abortion, and then at the end we'll have time for questions. So I am going to share my screen now. Okay, so sorry for the glitch there. I'm going to be speaking on chemical abortion. So just as an introduction, what is chemical abortion? Well, it has different names. Sometimes it's called chemical abortion. Some people refer to it as the abortion pill. Some people, medication abortion, medical abortion, those are all the same things. Chemical abortion is not emergency contraception or what's sometimes called the morning after pill. That's something different that we're not going to be discussing today. So I'm going to be talking about chemical abortion. And this is accomplished with two medicines. The first one, mifepristone, causes the baby to die. And the second one, misoprostol, causes the contractions to expel the baby. So just as an overview, the medicines, mifepristone, also called Mifeprex or RU486, you may have a different name in your country, is given 200 milligrams orally on day 1. So mifepristone is an anti-progesterone, and progesterone is required to maintain the pregnancy. So it blocks the progesterone receptors in the uterus, causing fetal death. Then 1 to 2 days later, the woman takes 800 micrograms of misoprostol, and that causes contractions to expel the baby. And the typical course for a woman is bleeding and cramping, similar or greater to a heavy menstrual period. Average bleeding lasts 9 to 16 days, but some women, 8%, bleed more than 30 days. Women pass the pregnancy at home or at their location of their choice. And some women describe this as very severe cramping and bleeding, like being in labor. So we're going to go into all this more detail, but just as an overview, the most common events are retained tissue and hemorrhage, both of those possibly requiring a D&C or sometimes referred to as a uterine aspiration. It's also the risk of infection or transfusion. Other adverse events, if you want to call them adverse events, ongoing pregnancy, meaning the woman still has a live pregnancy. And the other, also ectopic pregnancy, I want to mention. Now, ectopic pregnancy isn't caused by these medicines, but if there's an ectopic pregnancy, which is a pregnancy in the fallopian tube or elsewhere outside the uterus, these medications don't treat ectopic pregnancy. So there can be a delay in treating the ectopic pregnancy, and that can be catastrophic. So in my country, the United States, there actually has been 29 deaths for medication abortion reported, and actually 2 of those were from ruptured ectopic pregnancies. So I just want to compare to medication abortion or chemical abortion to surgical abortion. So surgical abortion, often referred to as a D&E or dilation and evacuation, or sometimes called a D&C. That is a outpatient procedure where the cervix is dilated and then the contents of the uterus are suctioned out. And it's an outpatient surgery. The woman comes in, she goes home typically the same day. So why would, what's the difference? What's the advantages? Why would someone want a chemical abortion? Well, sometimes women don't want to have surgery. It may be more convenient. She may not have access to surgical abortion. She may want privacy. There is a perception that a chemical abortion is safer than a surgical abortion. It's actually not. It's more dangerous. With a chemical abortion, it occurs outside of the clinical setting. So the woman is delivering her dead baby at home, and there are more complications. A surgical abortion, as I said, it's more effective. There's fewer adverse events. It's one short procedure, and it allows for a direct assessment of the pregnancy tissue, which sometimes can be important. So I, preparing this talk, learned a little bit about abortion in India. You probably know these things, but just to review, in India, abortion became legally available in 1971, the Medical Termination of Pregnancy Act. And then in 2002, chemical abortion with mifepristone and misoprostol was approved up to 49 days gestation. So that's 7 weeks pregnant. Then a year later, they amended the act to permit certified providers to prescribe the drugs outside of a registered facility, as long as there were emergency backup facilities available. And then in 2010 in India, it was approved. They extended that from 49 days to 63 days. So that's 9 weeks gestation. So the Medical Termination of Pregnancy Act in India requires a prescription, but most patients just get it from the pharmacy without a prescription. So pharmacy workers are often the first point of care. Most facilities that provide chemical abortions are in urban areas in the private sector. It's my understanding that these drugs can be purchased either separately or in a combination pack. This is a very good study by Singh and others reviewing abortion in India. So this is data from 2015. 33% of the pregnancies in India ended in abortion. And in a 1-year period in 2015, there were almost 16 million abortions. Now, where do these occur? Only 22% occur in healthcare facilities, and the rest are outside healthcare facilities. So, and 5% of those are kind of non-traditional methods other than medication abortion. So the majority of women in India who get an abortion are doing this kind of on their own. The method used, 81% were chemical abortion, 14% surgical, and 5% other methods. This is a chart from the Guttmacher Institute. This website has a lot of good data information. So this is in 2015, 2019, there were 48.5 million pregnancies per year. And of those, 44% were unintended. And of all the unintended pregnancies, 77% ended in abortion. So I want to go over the pharmacology of these two medicines. So mifepristone, as I said, is an anti-progesterone. It is called a selective progesterone receptor modulator. It binds to the progesterone receptor in the uterus with a higher affinity than progesterone itself, therefore acting as a anti-progesterone. And since progesterone is required for the baby, this lack of progesterone causes fetal death. However, mifepristone also has anti-glucocorticoid activity. It was initially developed for the treatment of Cushing's disease, but it also blocks cortisol receptors centrally and peripherally. It does have a long half-life, 30 hours. In some people, it's up to 90 hours. Now, I want to talk a little bit about mifepristone and a very rare infection, Clostridium sordelii. A few years after chemical abortion was approved in the United States, 4 women died in the United States due to a rare bacteria, Clostridium sordelii. And so the organizations held a workshop to look into this, and they did find that mifepristone is associated with this rare infection. So what is the mechanism for that? Well, the anti-progesterone activity results in the uterus being a favorable nidus for infection. And then the anti-glucocorticoid activity impairs the innate immune system. So it interferes with the controlled release and functioning of cortisol and cytokines. And in Clostridium sordelii infections, there's potent exotoxins and endotoxins. So unfortunately, if a woman has a Clostridium sordelii infection, it's actually almost universally fatal, very quick and course, and usually ends in death. There is a black box warning in our labeling here about Clostridium sordelii, as well as prolonged bleeding. And in the United States, there's been at least 8 U.S. deaths from Clostridium sordelii sepsis after medication abortion. In fact, infection was the most common cause of death. So I want to move on to the second drug, misoprostol, sometimes here called Cytotec. So misoprostol is a prostaglandin E1 analog. It's approved here to prevent gastric ulcers for those who are on long-term non-steroidal anti-inflammatory drugs. It inhibits gastric acid secretion. It protects mucosa, but it also produces uterine contractions. Now, as an obstetrician, I've used this drug many times for good uses for cervical ripening, for inducing labor, later in pregnancy, for controlling postpartum hemorrhage. But this drug causes contractions, and so that's how it's used in chemical abortion. Common side effects: nausea, vomiting, diarrhea, headache, dizziness, fever, chills. Those are common. And now misoprostol is actually teratogenic. So mifepristone, the first drug, does not have any known teratogenic effects, but misoprostol does. It's associated with a condition called Mobius sequence, which is facial or abducens nerve palsy, central hypoventilation, and terminal transverse limb defect. So this poor child here was a survivor of mifepristone abortion with Mobius sequence and ended up unfortunately dying. So I want to talk a little bit about the complications of these medicines of chemical abortion. What do we know and what don't we know? I'm going to go through some studies, some of the more important and reference studies. So this was a systematic review by Chen. They looked at 20 studies, 34,000 patients, and they found that in chemical abortion, ongoing pregnancy, so the woman still has a live baby, is 0.8%. Now that's up to 9 weeks or 63 days. But from 9 to 10 weeks, 64 to 70 days, it's actually almost 3%. So, and you'll see this throughout the talk, where the farther along in pregnancy, it is less likely to kill the baby. It also has higher complications. They found that the efficacy, so meaning not needing a surgical abortion, was 96.7%. But in that, again, 9 to 10 weeks, it dropped to 93%. Transfusion up to 0.6, ER visit up to 3.7, hospitalization up to 0.9, and surgical evacuation, other than for ongoing pregnancy, was up to 4.2%. So let me tell you about this study. I've studied this study, and it's interesting because most of the data from this study was from two large studies, retrospective. Gatter, in Gatter study, 15% were lost to follow-up, so were excluded. And this study didn't look at ER visits. And the other large study, 17% were lost to follow-up and excluded. And that study did not look at hospitalization or ER visits. So I'm going to talk about another study, another systematic review by Raymond. In this study, they had 87 trials, 120 trial groups, so 45,000 chemical abortions. And you can see what they found. Efficacy, 95.2%. Ongoing pregnancy, 1.1%. Transfusion and hospitalization were low, although in one study up to 1%. So I want to point, notice this efficacy. So 95.2%. Well, that sounds good. That still means that almost 5% of women are going to have to find a facility to get a surgical completion. In this systematic review, most of the studies were small. Only 7 had more than 1,000 patients, various doses and routes of medication. And as I said, almost 5% required surgical completion. Here's another retrospective study, this one comparing chemical to surgical abortion. Again, you can see these numbers: efficacy, 99.6, ongoing pregnancy, 0.4, surgical aspiration, 2%, major complications were low, persistent pain, bleeding, or both, 1.8, and any adverse event, 2.2%. Now they say efficacy of 99.6, but they're really not including the 2.2% of surgical aspiration. So we're really, they're looking at the ongoing pregnancy. So in this, it's just a definition issue, but I just wanted to point that out. Also in this study, 16% were lost to follow-up, and those lost to follow-up were not excluded, but they were assumed to have had an uncomplicated complete abortion. Even so, in this study, they found that chemical abortion has 4 times the risk of failure compared to surgical abortion, and ongoing pregnancy increased by 50% for each further week of gestation. This study is an important study done by Cleveland. And in this study, they looked at all the Planned Parenthood abortions in the United States. So that's the major abortion provider here, over a 2-year period. So this is a big study, over 200,000 chemical abortions. And they looked at these 8 adverse events: ER treatment, hospital admission, transfusion, IV antibiotics, infection requiring antibiotics or admission, ongoing pregnancy, ectopics, and death. And you can see these numbers look low, are low. And then, so the authors said, well, our reported overall complication rate was 0.65%. So this study is often quoted to say how safe supposedly chemical abortion is. However, the study did not look at the most common adverse events, retained products of conception or hemorrhage without transfusion, or any other events other than these 8. They also did not evaluate or include incomplete abortion if it was treated at their clinic. And also the data are only those reported to or received by Planned Parenthood. So let's say a woman had bleeding and she went to the ER and was treated at the ER, and Planned Parenthood didn't know about that. Well, that wouldn't be included as a complication. And actually most adverse events in my country are not treated by the abortion provider. So, and the other thing in this study, they never disclosed the percent loss to follow-up. So, I want to look at some international studies. This was a study in Sweden. They looked at all abortions at a hospital for a 7-year period. 3/4 of those were chemical abortion, less than 12 weeks. Now, all patients had a pre-abortion evaluation. So they had a gynecological visit, a visit at the clinic with a gynecologist. They had a pelvic exam, an ultrasound, and screening for infection. Now, this is important because many times women take these pills without having these. They should have all of this. They should have an ultrasound. They should have a visit with a doctor. But having these will reduce their risk of problems. So in this study, for chemical abortion less than 12 weeks, 4% were incomplete. And the overall complication rate was 7.3%. And then that, interestingly, over that 7-year period, the complication rate increased from 4.2 to 8.2. This is another important study, Niininmäki in Finland. Now in Finland, they have a national health registry and data linkage. So this is really complete data. But they looked at all women in Finland undergoing abortion from 2000 to 2006, 42,000 women. They looked at up to 9 weeks gestation or less, and they followed them for 6 weeks post-abortion. And what they found, women who had hemorrhage, chemical abortion, almost 16%. Surgical abortion, 2%. So 8 times the risk of hemorrhage. Women with any adverse event, chemical abortion, 20%. Surgical abortion, 5.6%, almost 4 times the risk of any complication. This is the same information, just in a chart form. The blue is the chemical abortion, the green is the surgical abortion. And you can see, we talked about any adverse event and hemorrhage. Incomplete abortion was higher in chemical abortion, surgical reevacuation was higher, infection for both was 1.7%. So other studies have borne this out, that in this study I just talked about, 4 times the risk of complications. In a study by Upadhyay, 6 times the risk of complications for chemical abortion compared to surgical. In Ireland's study, 4 times the risk of failure in chemical abortion compared to surgical abortion. And a study in 2021 by Studnicki, chemical abortion had more than 2 times as likely to result in an abortion-related emergency room visit. We also know, as I mentioned, that risks increase with gestational age. So this was a study by Mentula comparing first and second trimester chemical abortion. In a first trimester chemical abortion, surgical evacuation was needed in 7.9%. In the second trimester, it was 38.5%. Likewise, infection, 1.9 in the first trimester, increased to 4% in the second trimester. This is important because it's very important if a woman's going to have this, take these medicines, that she know how far along she is. So I want to talk a little bit about self-managed abortion. In my country, it's becoming very much more common and is being pushed. As I mentioned, in India, really, at least 3/4 of the women there, most of the main way is women taking these pills on their own or self-managing their abortion. In the Singh study, he said little is known about what kind of information women are getting when they obtain this method from chemists and informal vendors, and whether they are taking it correctly. This is an important evidence gap that should be further explored. This is India. This is a different study by Singh, self-managed abortion. Again, chemical abortion accounts for over 70% of the abortions in India. I'm sorry, chemical abortion outside of medical facilities, so self-managed abortion. And this paper looked at the complications from induced abortion in 6 Indian states, which I've listed here. And it's very interesting. The complications that were treated at a health facility, percent complications, range from 8.2 to 45.8%. I'd be interested, you all to know where these are and what the difference is and why there would be more complications. I can't comment on that. And the most common complications, similar to what we've seen before: incomplete abortion, prolonged abnormal bleeding, infection, injury or perforation or laceration, sepsis, shock, and shock. Sorry, that went right to my next slide. This was a different study by Aurora, where they looked at 112 women who went to an outpatient department after taking medication for inducing abortion. So they took this on their own or from non-formal providers. So 87% obtained the drugs over the counter, the rest from a local medical practitioner. Only 25% used the correct dosages. And when you look at this gestational age, 22% of these were over 9 weeks. So it's approved in India up to 9 weeks. It's improved in the United States up to 10 weeks, but again, the farther along you get, the higher risk of complications. So the women this is not the percent complications, but of the women who had complications, most of those were abnormal bleeding. 21 of them had hemorrhagic shock and required a blood transfusion. 6 of them had an ectopic pregnancy. 85% required a D&C. And interestingly, 2 women had a pregnancy at either 19 or 20 weeks and ended up getting an abortion. And 1 woman had a pregnancy at 22 weeks that was still alive and continued the pregnancy. So, women are taking these medicines at 19, 20, 22 weeks. This is not safe. So we talked about complications. I want to just point to some additional concerns with self-managed abortion. One, as I said, is gestational age. How far along is she? Most women use their last menstrual period to determine how far along they are. Women may not even know when their period was. In fact, one study showed that 40% of women, their due date had to be corrected because their last menstrual period was off. So it's not really a reliable way. And so if women take this again at 10, 11, 12 weeks instead of 6, 7, 8, 9 weeks, there's going to be increasing complications. Another concern is ectopic pregnancy. If the pregnancy is in the tube or elsewhere, if it's not in the uterus, these medicines will not treat that. And ectopic pregnancy, if not treated, will grow and rupture and cause internal hemorrhage and can be catastrophic and cause death. Well, ectopic pregnancy is 2% of all reported pregnancies, 2.7% of pregnancy-related deaths, and half of women with ectopic pregnancies don't have risk factors. Sometimes they'll say, well, do you have any risk factors? Also, the symptoms, bleeding, pain, well, they can be attributed to the abortion process. So that just delays the time for the ectopic to be treated appropriately. Unknown RH status is another issue. So about 10% of women are RH negative. And we know that RH negative women in a pregnancy, any pregnancy, should receive something called RhoGAM or RhD immune globulin. Because if they don't, if they are not treated, about 13% to 16% of those women will have alloimmunization, meaning she's forming antibodies against the pregnancy. And then in the next pregnancy or a future pregnancy, she can, those antibodies can affect the baby. In fact, if that baby's untreated, 14% are stillborn. And of those that are not, or the rest, half die in the neonatal period or have brain injury. So that's kind of, I just have a few more minutes left. I want to shift gears here from chemical abortion to just talk about, well, what is abortion and who's being aborted? And I think that points to the question, when is a human a person? Is this a human person? I think we would all say yes. Is this a human person? This is a baby in the womb. So I would propose that the unborn at any stage of development is a human being. For one thing, they're distinct. Right at fertilization, that human being has his or her own unique DNA. Their hair color, their eye color, their sex is already established right at fertilization. Also at fertilization, the unborn is an organism, not just a tissue or a clump of cells. They're also human. They're not a cat or a dog or a horse. They're human. That human being is also living. They grow, they metabolize nutrients, they respond to stimuli, and they feel pain as early as 12 weeks. Speaking of pain, this is a very important article by Stuart Derbyshire, who earlier back said he's pro-abortion, he's not pro-life. And earlier on, he published a study saying babies don't feel pain till 25, 26 weeks. And in 2020, he published this paper. He reconsidered and said, overall, the evidence and a balanced reading of that evidence points toward an immediate and unreflected pain experience mediated by the developing function of the nervous system from as early as 12 weeks. Just another comment, cardiac development. The heart starts to develop as early as 16 days after fertilization. And the first heartbeat at 22 to 23 days. So a beating heart can be seen on ultrasound 4 weeks after conception. I've seen that many times. This is a quote from Keith Moore. This is an embryology textbook, a medical school textbook. Human development begins at fertilization when a sperm fuses with an oocyte to form a single cell, the zygote. This highly specialized totipotent cell capable of giving rise to any cell type marks the beginning of each of us as a unique individual. This is by Dr. Maureen Kondik. Embryos are genetically unique human organisms, fully possessing the integrated biologic function that defines human life at all stages of development, continuing throughout adulthood until death. The ability to act as an integrated whole is the only function that departs from our bodies in the moment of death and is therefore the defining characteristic of human life. Bernard Nathanson was a physician in the United States who performed many, many, many abortions. And then later, he changed his mind. He saw a baby on ultrasound and he became very pro-life. And he said, there's no longer serious doubt in my mind that human life exists from the very onset of pregnancy. So what's the difference? You might say, well, they're different in size. And so maybe that doesn't make the unborn a person. Well, we wouldn't say that a 2-year-old's not a person because they're not as big as a 20-year-old. You could say they're not as developed. Likewise, a baby's not as developed as a 2-year-old. A 2-year-old's not as developed as a 15-year-old. A 15-year-old's not as developed as an adult. That doesn't make someone not a person. Their environment. One of them's in the womb, in the uterus, one of them's outside. But I'm a person, whether I'm in my house or outside or wherever I go, that doesn't change my personhood. You could say dependency. Oh, that baby's dependent on his mother. However, in many ways, all of us are dependent. You know, a newborn baby is dependent on his or her mother. A 10-year-old is dependent on his or her parents. So that doesn't make a difference. And finally, the Carnegie stages said this from the very beginning, Carnegie stage 1A, the human embryo produces specifically human enzymes and proteins. He or she forms specifically human tissues and organ systems and develops humanly continuously from the stage of a single cell human embryo onward. Unless prevented, a new human being, a human embryo, will continue to grow and biologically develop continuously until his or her death, just like a fetus, infant, toddler, child, teenager, and adult human being. And lastly, before the end, just a quote from Mother Teresa: how can there be too many children? That is like saying there are too many flowers. So that's all I have. We're going to take some time for questions. I want to thank you all so much for coming.
Thank you, Dr. Christina, for that lovely presentation that actually gives us a lot of clarity with regard to the adverse effect that chemical abortion can have, especially the drugs that you've mentioned. And there is a question here that is related primarily to what you have presented in terms of the data. Here it says, this is a question by Anne Mary George. And so she says the drug mifepristone is being widely used as a part of phase 3 trial in reducing size of fibroids. Are they safe anymore? Did you
So
get
the question is about using mifepristone to treat fibroids. I don't believe that is standard of care. I don't know the data on that specific use of mifepristone. It's certainly not, I think you're saying it's used widely in maybe in India. I don't believe it's used widely here. But I can't really comment on more specifics about that.
Okay. And there's another follow-up question that says, and in India, even miscarriages and incomplete miscarriages up to 9 weeks are managed by doctors with the same drugs rather than expectant management.
Mm-hmm. Yes, I don't know if there's a question there, but yes, and that is being done here as well. So, in a miscarriage or what we call a spontaneous abortion, so the baby has already died, there's three ways to treat that. One is surgically with what we call a D&E. One is expectant management. So most times the women will pass everything on her own, or drugs like these. We've typically used just the misoprostol, but now there is more frequent use of also using mifepristone.
Okay. Now, just to shift gears a little bit, to change the variety of question, there is a question that I have here which says, one particular survey says selective abortions in India could lead to fewer girls, specifically in one particular state that I shall leave unnamed. How do you see the spiritual component of God in the center as life giver?
Okay, great question. So what, can you read the question part again?
Okay. Now this is
So it's
a
about
question.
girls being aborted more than boys?
Yeah, more
And
than
what was-
boys. So
Uh-huh.
how, based on this data that we have, according to this survey, the question which is more philosophical, how do you see the spiritual component of God in the center as life giver?
Well, that's a great question. And so we're talking about women getting abortions because they have a girl instead of a boy. I think that's probably has been common also in China. So yeah, I think spiritually, from my personal standpoint, I see that God has created the everyone in his image, and girls, boys, from the one cell stage to old age. So yeah, I would don't think that would I would have a problem with that personally, yes. Plus, we're also valuing then, there's social ramifications of that where now you have more boys and girls and all of that. But I think the main thing is that this little tiny baby or organism is made in God's image.
Sure. I think the answer that you've given, I'm sure that it is in light of a worldview that actually believes in the fact that everyone is created in the image of God. And so in light of that question, I think probably would it be correct, Dr. Christina, to probably say that it is each individual's worldview that would also define and determine or influence the way they look or the way that they value an infant or maybe an unborn baby as well, right?
Absolutely, yes. So your worldview, how you see everything, and is going to certainly affect what you do and how you value or evaluate different things. Correct.
Thank you. There's a question from Donna Robmay, and she is curious to know what is the legal status of chemical abortion in different states of the United States.
Okay, great. So a chemical abortion was approved in the United States in 2000. And similar to India, it was initially approved up to 7 weeks. Now it's approved up to 10 weeks. And so, and they, over that 23-year time period, the government has removed restrictions. And so women really can get this without seeing a doctor, without an ultrasound. It's quite problematic. But what happened then is, probably last year, the Roe v. Wade was overturned. So states kind of make their own choice. Now, there are some states that allow abortion up to term, and there are some states that have significant restrictions. There are some states that do not allow telemedicine, so the woman has to actually go see the doctor. There are some states where chemical abortion is not allowed. But, women can buy this on the internet, so they can still get it. But the laws do vary by states. Hopefully that answers your question.
Thank you. Thank you. Now, there is a question on the chat box from one of our chapter officer. And Jacob has this question. He says, if a person goes through chemical abortion, should the person go through postpartum counseling sessions?
So by counseling, do you mean like mental health counseling, or is that what is meant by that? Okay.
Yes.
So, you know, a lot of women do have mental health problems after abortion. And so I mean, I think it depends on the woman. I can't say that every woman must, you know, that's important, but I think many women really struggle with this. It's women get abortion for different reasons, and they obviously at the time felt it was the right decision, but a lot of them, I know I've seen many patients who just regret it. And so, yeah, I think if that's something that if that's where the woman is emotionally, might be helpful for her to get some counseling.
Thank you. Thank you. We have a couple of questions more, and I think we just have about 10 minutes in our hands. And just to shift gears a little bit, here is a question which basically says, if someone says, it's my life and I have the choice to decide, why I need to listen to someone to say that this is not right? How would you respond to that, Dr. Christina?
Oh, that's a great question. So again, I guess it goes back to your worldview. And, you know, I've presented a worldview that this, you know, it's my life, but there's a woman who's pregnant has another life inside of her. And that life is a distinct human being. And so, you know, it's pretty universally among biologists and embryologists that this baby is a human. Now, some people would say, well, it's a human, it's not a person. I believe it's a person from conception, but yeah, it does depend on your worldview. As an obstetrician, I feel that I have two patients, the mother and the baby. So if that baby inside the woman's womb is a separate person, then we're talking about, well, what are the rights of that baby versus the rights of the mother? I think it really comes down to that argument.
Well, I think that answers the question pretty well. And I think, you know, looking at your presentation, especially the one that you've mentioned with regard to the statistics with regard to India, and it's quite staggering that in the year 2015, as reported by this article, that 15.6 million abortions in India took place. And so here is a question in light of that, which says that we as a country soon, we are overtaking China in population, right? And what's your take on, as a Christian, do we need to go with the flow or can we have some control?
Can you maybe rephrase that? I'm not sure I understand what do you mean by control?
Control in the sense you know, should we, I think the question is just given in that form, and I think I don't know what exactly the questioner means. And so let me just read it again.
Okay.
We as a country soon, we are overtaking China in terms of population, the size of population. What's your take on, as Christians, do we need to go with the flow? That means allowing as things, you know, permit, or should we have some kind of a control? Could be by, you know, authorities, or, you know, like that policy that we have in some countries that you cannot have more than a certain number of children. Probably, I'm just, you know, trying to guess here based on the question that I have with me.
Well, there's a couple ways you could look at control. If you're talking about government control, you know, China had their one-child policy, and now they've removed that because it really worked against them. And you know, men couldn't find wives because everybody wanted to have boys, and you know, so I personally I don't want my government telling me how many children I should have or not have. I think women have, you know, there are choices before you get an abortion, that women in most instances have some control over. So I guess that would be my comment on that question.
Okay. Now, here is, I think, a quite sensitive question that has been raised by someone. Probably I'll just take two more questions. This is one and another one last. And this question says, when a rape victim goes for abortion, how do you draw the biblical line to say it is wrong or allowed? Did you?
Whether abortion is allowed in rape. Well, you know, rape is terrible, terrible trauma. I mean, it's just so heartbreaking, that situation, and it's far too common. And abortion is often put out as a kind of, well, then you should be able to get an abortion if you're raped. The thing is, abortion after rape doesn't treat the trauma of rape. It actually adds a second trauma. And if a woman is raped and an abortion punishes the baby, the victim, we really should be punishing the perpetrator. So again, rape is a terrible thing, but abortion doesn't fix it. It doesn't fix the trauma. It doesn't help anything.
Sure. And I think in light of that, it would be important to probably consider even the role that the community especially comes together to kind of, help heal the situation, yes, especially in that context, and especially considering the fact that, the scripture has some very important, valuable suggestion even in that context. Now, let me take one last question. I see there are some questions that are popping up in the chat box, but there is one question from Krishnam. And I think this question says, many women say men cannot talk about or oppose abortion as they don't understand it. So, quote unquote, is that a valid argument? Or in other words, if I may amplify his question, what is the role that men have in terms of being a solution to this? Maybe you can.
Right, great question. A baby takes a man making a baby takes a man and a woman. So he is still responsible. I mean, for that baby. I mean, in my country, women will say, well, you don't have any right, it's not your body. But again, if indeed that baby inside the woman is a separate human being and a person, then it's a whole different ballgame. And I think that some men will say, oh, well, my girlfriend, my wife got pregnant. Whatever you do, I'll support you. Well, that's not really helpful. That just pushes it on her. Really, I think that he, come on. I feel like saying to men in my country, step up, like be the father. This is your child. So, and on another hand, as a physician, I've never had a heart attack. Does that mean I can't treat a heart attack? So I think that, and again, it all goes down to your worldview and how you see this little human person in the womb.
Thank you. Thank you, Dr. Christina. I think that is all the time that we have for this evening's talk. And as someone said here in the chat box, someone by the name of Julia, she said, so enlightening. Thanks, Dr. Christina. And I, again, on behalf of the RTB APAC team and all of us who are here, there are a lot of physicians as well who are here on attendance. And I would like to say a big thank you. I think you have really added to the to our knowledge, to our understanding. And as you have rightly concluded, I think we all have a responsibility. We need to step up. There are people who are hurting as a result of wrong decisions that are being made. And so it is our hope and our prayer that we can contribute towards the solution rather than to add to the problem. So thank you for enlightening us with your talk. And I hope that all of us here have enjoyed thoroughly. And we will definitely be having you quite often on some other topic, because I do understand that as you have concluded your talk, you have hinted with the question of is the unborn baby a human being, and when does that person, so all of that we need to actually unpack maybe in the days to come. And so I would like to thank you for this. Do keep in touch with us. Do let us know in what way we can continue to bring topics and issues that are relevant for your life and even for your community as well. So once again, a big thank you. And as you leave, continue to just have a look at some of our resources that we have, which we'll be putting on display. So once again, have a great evening, and a big thank you to all of you, and to Dr. Christina in particular, and also to all the guests, and more importantly, to all the team of RTB APAC who's behind the scenes. So once again, thank you, God bless, and have a great evening ahead.